Jazakallah, Dr. Sakabeli. If there are any questions, please pass them up to the podium. In the meantime, I would like to ask a question to Dr. Irfan Alladin. How do you curb the increase in opiates as you're seeing, you can use that mic, as you're seeing these patients on chronic basis, and you can see that using the mic here.
How do you curb the use of opiates? Yes.
Yes, because if you're prescribing them on, if you're starting them on long-acting opiates, it is a commitment.
Right.
And then we know that this is not a therapy that is meant for chronic use.
Yes.
So how do you curb that in future and as they develop tolerance and dependence?
So I guess we go back to using the co-analgesics. First, an anti-inflammatory, which can be used, muscle relaxants, neuroleptic agents like your gabapentin, your pregabalin, and then you also have non-pharmacologic means, behavioral therapy, as well as meditation. And then we have the alternative therapies, which we discussed before, the acupuncture, the homeopathy, the chiropractic, and then we also have physical therapy. So all of these means we use to decrease the dependence on the opioids. But then again, there are certain patients who are on opioids for chronic pain, and some have much greater function. For example, driving. They find that in patients that have chronic pain, many of them drive better on the opioids than when they're not on the opioids for chronic pain. Because when they're not on the opioids, the pain is so bad, often they will have a response where they'll hit the gas pedal and have an accident. Or they'll accidentally jerk and hit the brake when they should not be braking and cause an accident. So there is a group of chronic pain, if patients which most pain management doctors do not want to see, who actually do better on opioids than don't. And this is by Dr. Russell Portnoy. He's the one who's done a lot of research in this, and Joseph Valenza at Kessler Institute in West Orange, New Jersey. It's where Christopher Reeve, Ben Vereen, and a lot of the big people were. So there is evidence that opioids do help improve function in a chronic, but in a controlled, safe setting.
So the follow-up for that would be, how do you document that?
Basically, I try each of these methods, or as what the patient is willing to try, and then document that I've tried all of those. And that way, if, God forbid, some of the big boys were to look at the chart, they say, oh, well, he tried acupuncture, he tried homeopathy, he tried Reiki, he did functional medicine, he did muscle relaxants, anti-inflammatories, topicals. This guy did everything. He didn't want to prescribe opioids, but there was nothing else, including dorsal column stimulators. Maybe he had a dorsal column stimulator, it worked for a year, but then he got infected, and there was pus coming out like a river. And then they tried an intrathecal pump, and that got infected. So there are patients where there's nothing else left except dua or prayer and opioids.
Okay. So the next question is, again, they're both for me. What does the evidence say about the short and long-term implication of surgical procedures such as laminectomies, discectomies, etc.? So I think it's the context. If discectomy is done for one level, single level disease responds very well, and the reoccurrence rate, if it was due to acute trauma, is not going to be as high as if it was a degenerative process. So laminectomy is the same thing if it is for an emergency decompression. And if it was an acute process, it will be different, versus if it is a multi-level decompression for a chronic degenerative spine. We have a neurosurgeon here. If I say something out of line, you can correct me on that, but that would be my answer. If it is single-level disease, evidence is great. That patient will do well. If it is multi-level degenerative process and they get multi-level laminectomies are going to render them unstable. They will need hardware to stabilize their spine. Obviously, the complication rate increases. Second question is, but before I ask second question, let me ask a question to Dr. Saqib Ali. You described spinal cord stimulator implantation, and you have mentioned that there's a company that is FDA approved for DPN, painful diabetic neuropathy. When do you choose to use one company versus the other, or do you have a bias for that? Mike, there's Mike.
In terms of diabetic peripheral neuropathy, the only company that's FDA approved is a company called Abbott. Now there's four big companies that do spinal cord stimulation. So Boston Scientific, a company that a lot of us have heard of, Medtronics, Nevro, and Abbott. Honestly, if somebody is skilled at placing spinal cord stimulator, it doesn't matter. They're all good. They all work well. Boston Scientific, they all have slight nuances in their lead system. Boston Scientific has this lead called Infineon, it's a very long lead, and it makes spinal cord stimulation quite easy because it covers so many levels. But they're all, in my opinion, they're all quite good.
Interchangeable, okay.
Yes.
Another question, at what point do you make the decision to undergo surgical intervention duration, severity, conservative approach first? So yes, rule of thumb, always surgical options are at the later part of the algorithm. We start with the more less invasive, more benign procedures that are going to have less complications because we're looking for a balance in risk versus benefit. If the risk outweighs the benefit, obviously we're not going to use that procedure. So earlier on in the algorithm of treatment of pain, whether that is back pain or neck pain, surgical intervention is going to be later. As a matter of fact, no insurance company is going to authorize a surgical procedure if the conservative approaches are not exhausted. So it's not the duration or severity, it is if the patient has pain that is disabling. So a person who is disabled cannot perform the activities of daily living, is now going to become a burden on society, and has undergone conservative therapy. That is good enough of a case to make to